We are here presenting the case of a congenital diaphragmatic hernia, CDH, diagnosed at 20 weeks ultrasound scan. CDH is a surgically correctable anatomical defect with unknown etiology. In just less than half of the cases, there are associated anomalies. It sporadically occurs with an incidence of about 1 of 4,000 of newborns. 84% of lesions are left-sided LCDH, 13% right-sided RCDH, and 2% bilateral. The diagnostic accuracy is poor. The diagnosis is possible only when a mediastinal shift occurs. In LCDH, the diagnosis occurs at about 26 weeks of gestation. A radioid displacement of the heart can be seen. A fluid-filled stomach or bowels are later on present within the thoracic cavity. In RCDH, the diagnosis is late, occurring at about 28 weeks of pregnancy. The right lobe of the liver usually turns into the chest with mediastinal shift to the left. The case we are showing here is peculiar in that only a slight mediastinal shift can be observed, with only a minimal rightward displacement of the heart. On a closer look at the transverse section of the chest at the level of the four-chamber view, a solid echogenic bowel-like area can be identified in the left side of the chest. This area presents a higher echogenicity than the lung tissue. An important feature to look for is the presence of a portion of the liver in the thorax. Indeed, 57% to 86% of cases of CDH, the hepatic parenchyma is partially herniated, liver up. Doppler interrogation of the umbilical vein and hepatic vessels may be helpful in this respect. Indeed, the presence of left portal vein branches at the level or above the diaphragm may indicate the liver herniation into the fetal chest. In our case, normal course and flow of umbilical vein and hepatic vessels are demonstrated. In this case, the heart is normal size, with the apex pointing to the left. However, because of the mediastinal shift, the cardiac axis lies at a 15-degree angle to the left of an anterior-posterior line drawn from the spine to the anterior chest wall, while the normal cardiac axis lies at about 45 degrees. In presence of CDH, an important measurement is the lung-head ratio, or LHR. A transverse section of the chest is taken at the level of the four-chamber view. The contralateral lung is measured. The longest axis is measured and multiplied by the longest measurement perpendicular to it, as you can see in the clip. This is placed of the head circumference, which is measured at the standard biparietal view. The LHR is a numeric estimate of the size of the fetal lungs, based on the measurement of the amount of the visible lung. High LHR values are associated with better outcomes. As you can see in the video, some bowel loops can be identified between the stomach and the umbilical vein. Probably, they are moving up to the thoracic cavity. The variety of possibly associated anomalies includes cardiac, central nervous system, renal, and gastrointestinal anomalies. In this case, no other associated anomalies can be observed. CDH may be a component of some genetic disorders, for example, the Fryns syndrome, mainly characterized by distal limb anomalies, the Cornelia de Lange disease, mainly characterized by abnormal facial profile, the Beckett-Wilmar syndrome, in which a large tongue is often observed. As you can see in the video, no limbs or facial or other anomalies can be detected in our case. The video shows normal hand with normal fingers. The management of CDH mainly requires, first, a chromosomal assessment and a fetal echocardiography because of the frequent association with genetic disorders. Secondly, an antenatal pediatric surgical consultation in order to assess the best time and modality of delivery. In this case, because of the only slight mediastinal shift, the favorable value of the LHR, the absence of polydramnios, as well as the absence of associated anomalies, we can be optimists. Thank you for your attention.